In previous video, we have seen what are hematinics and what is the role of iron, vitamin B12 and folic acid, and also the absorption of iron into the body, how it is absorbed into the erythrocytes and how it is absorbed in liver and various reticular endothelial cells, and how they are stored and how they are released into the blood. So today, let's see the preparation and dosages. So the first preparation will be in iron we will be having. So in this preparations, we have two types of preparations. One is oral iron and the next one is parental iron. Why we prefer this oral iron than parenterals? Because the route of administration will be easy. It is very easy, first point advantage. And next one, when we are using this dissociable ferrous salts, they are inexpensive and they will be having high iron content. As this is in ferrous salt form, it will be having a good absorption. So these are the advantages of oral iron. Let's see one by one. In oral iron only, we have different types of formulations. So if you see the first one, the first formulation is ferrous gluconate. In this ferrous gluconate, it will have 12% of iron, and if we are giving this one, we will give about 300 mg of tablet. And the next one is ferrous sulfate. In this ferrous sulfate, you will be having, if it is hydrated salt, you will be having 20% of iron, and if it is dried salt, you will be having 32% of iron. And not only that, as these are salts and we have known that all this oral iron, they will be inexpensive. This is the most cheapest form of other formulations. Like ferrous sulfate is the cheapest formulation when compared to other formulation like ferrous gluconate or ferrous fumarate. Next one will be ferrous fumarate. In this ferrous fumarate, you will be having 33% of iron and less water soluble, and it is tasteless. So what is the advantage of this? Most of the iron tablets will taste some metallic taste. So when we are taking that, it will be very horrible to swallow that one. But when we are taking this ferrous fumarate, it will be tasteless. So we can consider this as a advantage. When compared to above these two, this have 33% of iron. So when you are comparing in iron content also, this is better than previous two formulations. And next one, it will be colloidal ferric hydrate, and this one have 50 percentage of iron, and this colloidal ferric hydrate will available as a drops. They are available as a drop. So this drops we have to take 50 mg per ml drop. So next one is carbonyl iron. This carbonyl iron is the purest metallic iron. This formulation is available as a fine powder particles, and these are prepared with a highly toxic compound called as iron pentacarbonyl, and this is very toxic compound. This formulation will be absorbed in our intestine, and the bioavailability will be 3 by 4 of ferrous sulfate. We have other forms of iron preparations like ferrous succinate, iron choline citrate, and iron calcium complex. But this will be having less iron and they won't have that much absorption than these five irons. Okay, so mostly we will prefer this five irons only, and if we are taking combinations of this iron and vitamin drug, so nowadays it's very common that everybody, independent on what iron content they are taking this multivitamins along with this iron, so that they can promote their health. Let's see the adverse effects of this iron. And the most complicated thing of oral iron is constipation and gastric irritation. So when we are taking any iron tablets, these two will be very common. So let's see the adverse effects. All this constipation, epigastric pain, heartburn, and bloating will be due to this gastric irritation only, and straining of teeth. So when we are taking this iron, I told you that we will take colloidal ferric hydroxide like a drops. When we are taking that one, that will stain your teeth, and not only that, that will stain our teeth. So this teeth will become yellowish color, and you will be having black color scars on your teeth. That's because of this iron. And metallic taste, as I told you, each and every tablet will taste as metallic flavor except ferrous fumarate. And next one is colic. Colic is the baby will start to cry. We don't know the reason why baby is crying, but she will feel uncomfortable in their stomach and they will start to cry. Though the baby is very healthy, she will cry always. So next, let's see this parental iron. Mostly we won't prefer this parental iron, but we do have some conditions in which we will take this parental iron. Those are, the first one will be when we are taking this oral iron, that will upset the bowel very much. They won't be able to tolerate this iron because of this gastric upset. That's why we won't prefer this oral iron always. And the next one will be failure to absorb this oral iron due to some malabsorption or IBD, which is inflammatory bowel syndrome and chronic inflammations. All this will decrease the absorption of this iron, as well as it will also decrease the utility of this iron in the intestine. As iron is absorbed in our small intestine, it won't get absorbed properly, and we won't get much iron. That's why we will take this parental iron, which will go directly into circulation, and that will store in our liver, and whenever we need it will be releasing that one. And non-compliance to oral iron. What is this non-compliance? When the patient is not able to take this oral iron, or when the patient is refusing to take this oral iron, then we will call it as non-compliant. And next one will be when there is chronic bleeding, there won't be sufficient iron in our body. For example, there is inflammatory bowel disease. In this inflammatory bowel disease, there will be more chronic bleeding day by day. So we won't be able to control that bleeding, and most of the iron is lost during this bleeding. Okay, for that patients we will give parental. So next one is when the patient have this chronic kidney disease, as we know that RBC is produced from this erythropoietin. So along with erythropoietin, we will give this parental iron, because when we are giving oral drugs, it won't reach the demands of our body. So for immediate effect, we will give this parental iron. So next one, let's see the calculation how we have to give this iron to patient. So if we want to give in mg, this is the formula: 4.4 into body weight in kgs and hemoglobin deficit. So how to calculate this one? Let's see. So this is our iron requirement in mg. So 4.4, this will be constant for everybody. And body weight, let's take if the person is 60 kgs. And next one will be hemoglobin deficit. How we will calculate this hemoglobin deficit? Actually, a normal person, like if it is female, they should have 12 to 14% of hemoglobin, and if it is male, 14 to 16. So the middle number will be 14. So mostly we can't take exact 14. So we have to take 14.1 or 14.45 like that. But anyways, let's take it as 14. And think the patient have only 9% of hemoglobin. Okay, grams by deciliter. So if the patient have only 9%, then the calculation will be 60 into 14 minus 9, that means 5. This will be your hemoglobin deficit. So the original one, which is 14, minus the normal count what patient is having. If it is 9, 10, below 9, it is considered as deficit only. But anyways, anything below this 12 is considered as deficit only. So now we have 5. So the count will be 4.4 into, you will get 13.1320, which is divided by 100, and the final will be 13.2 mg. Okay, but we will give it as round, it might be 10 mg or 15 mg. That's how we have to calculate our iron requirement. So when we are talking about this parental iron, we have to remember that we should not give ionized salts of iron, which we will give orally. So when we are giving this ionized salts as an injection, they will be having a stronger protein precipitating action. So that's why we won't prefer this ionized salts as an injection. So next, let's see iron dextran. This iron dextran, which we will give as IM as well as IV. Okay, and we are using this drug from more than 50 years. So let's see the first one, which is IM. In this, we will give this injection deep into this gluteal regions. Okay, using this Z-track technique. What is this Z-track technique? If you see here, this is how we will give this drug. So through this Z-track technique, we have to give 2 ml daily, or this 2 ml we can give on alternate days, or if we have more iron deficit, then we have to give 5 ml on each side of the muscle. For example, if we are giving to our hand, to each side of this hand, that means for both hands, on the same day we will give 5 ml of drug. When we are giving this intramuscularly at local area where we are giving this drug, that area will be paining like hell. The pain will be for longer period of time. So if we see this intravenous, we will take 2 ml of 100 mg of iron, which is injected IV for 10 minutes. Like we have to inject the drug very slowly. As this is iron, we have to give this injection for 10 minutes. Okay, otherwise we have to dissolve this drug, this 100 mg of drug, into 500 ml of glucose or saline solution, and we have to give this for 6 to 8 hours. But when we are giving this, we have to keep the patient in observation, because when we are giving this, the patient may experience some complications like giddiness, tightness in chest. So let's see the adverse effects of this parental drugs. We have two types of adverse effects in systemic circulation and at the area of this injection, that is local area. If we see this local area, when we are giving, there will be much pain at the site of this IM injection, and the whole area will become very pigmented. That means the whole area will become black or reddish black in color. And next one will be sterile abscess. Sterile abscess means infection in that area, and this is mostly seen in old patients. In systemic, we will be having fever, headache, joint pains, flushing, palpitation, chest pain, dyspnea, lymph node enlargement, and anaphylactic reactions. And in some cases, this anaphylactic reactions will result in vascular collapse. Also, the patient may die, but this vascular collapse and death will be in very few patients. So let's see the uses of this. The first use will be, we will use this for iron deficiency anemia. So if the patient is having anemia due to this iron deficiency, then we will take it. Or if the patient is having any malabsorption due to chronic inflammatory diseases, or due to IBD or any ulcers, then we will suggest this type of iron. And to raise the hemoglobin levels also, we will give this iron. And not only that, we will use this as prophylaxis. In this prophylaxis, for example, if any person met with an accident, and if we feel that the patient lost so much of blood, to balance this iron in the body, then we will give this drug as a prophylactic. And not only that, in most of the menstruating women, due to this heavy bleeding, we will think that they will lose so much of iron. That's why doctors will suggest, like when they are bleeding more, doctors will suggest this iron tablets as a prophylactic treatment. And also in pregnant and lactating women, we don't need to check the iron content to them, because as they are sharing their all iron content with the fetus, they have to definitely be on this prophylactic treatment. And we will use this in megaloblastic anemia also. Megaloblastic anemia is mainly due to the deficiency of vitamin B12 and folic acid. But this may also cause iron deficiency. To compensate that one, we will give iron. So when we are giving this iron as a safety measure, what will happen? We won't get the deficit of this iron. Okay, that's why along with vitamin B12 and folic acid, we will also give this iron. So next one, let's see this acute iron poisoning. So what is this acute iron poisoning? It will be mostly in infants and children. So if children take 10 to 20 iron tablets at a time without knowing, then they will face this acute iron poisoning. This is serious toxic to the patient and they may die also. To avoid that, we will give this treatment. So let's see the treatment of this acute iron poisoning. So before going into treatment, let's see the order of these complications and how it will start. First one will be vomiting, and the next step is abdominal pain. Then that will leads to hematemesis. Hematemesis is blood vomitings. So the person who takes more iron tablets, the person will have this blood vomitings. And next one will be diarrhea. Fifth one, lethargy. Sixth one will be cyanosis. Seventh one is dehydration. Eighth one, acidosis. Ninth one, shock, cardiac collapse, and final one, which is 11th one, death. First, it will start with vomitings, but the whole iron tablets won't come outside, so most of the iron will be inside only. So next one will be abdominal pain, hematemesis, diarrhea, lethargy, cyanosis, dehydration, acidosis, shock, and cardiac collapse, and finally the person will die. In most of the patients, this death will happen within 12 to 36 hours. But in few patients, within 6 hours, they will die. So if we want to do any treatment, it have to be before 6 hours, because we don't know which type of patient he is. If we are seeing the patient in hematemesis, then only we have to react very fast. And all the steps will happen within no time. In this step, we have to be very careful and we should not allow the person to get dehydrated. So let's see the treatment of this. First, we have to stop the absorption of iron from the gut, because furthermore absorption of iron in the gut, what will happen? There will be more worsening of the situation. So first we have to stop the absorption of iron. Next one, we have to induce. In this stopping of absorption, we have two steps. One is we have to induce this vomitings. We have to perform gastric lavage. So how we have to perform this gastric lavage? We have to give sodium bicarbonate solution. When we are giving this sodium bicarbonate solution, what will happen? We will take all the insoluble iron from the stomach. They will be, like for example, if that person have taken 100% of iron, only 50% of iron have absorbed, and 50% of iron is absorbed. So the remaining 50% is not absorbed and it is insoluble. Then the 50% of the iron which is not absorbed, we have to eliminate that one. So that will happen only through gastric lavage or through inducing vomitings. So we have to give this sodium bicarbonate solution to eliminate this iron which haven't been dissolved. And next one, we have to give egg yolk and milk. We have to mix this egg yolk into milk and we will give that through oral. So this iron will get complex and it won't absorb in the body. So that's the reason we have to give this egg yolk or milk. Most of the time for any poisoning we will be suggesting this activated charcoal for absorption, because when we are taking activated charcoal it will absorb the poison. But here activated charcoal won't act on iron because this is not any free radical, that's why it won't absorb iron. That's why we should not give activated charcoal. Instead of activated charcoal we will give milk which is mixed with egg yolk. And next, so what to do if the 50% of iron is already absorbed in that patient? So to this patient we have to give this desperoxamine. So when we are giving this desperoxamine, which is an iron chelating agent for iron poisoning, this is the best drug. So we will give this injection IV. We will give this drug as IM 0.5 to 1 gram, which is 50 mg per kg. This will be in children. Okay, and we have to repeat this dose for every 4 to 12 hours. But if the patient is at the stage of shock, we can't give this to IM because it will take much time to reach into the circulations. So we have to give IV 10 to 15 mg per kg every hour. Here for 4 to 12 hours. But here we have to inject this drug for every hour. That too 10 to 15 mg per kg. If the patient is in unconscious stage, then we can increase this dose to 55 mg per kg also. Okay, frequency will be the same. We can give 75 mg per kg per day. Okay, and we should not, as I'm told, as I'm saying that you can give for every hour, that doesn't mean that you have to inject more drug. It should not be more than 75 mg per kg per day. So if we are increasing this dose, this will also cause side effects to the patient. This may also cause disadvantage to this patient. If we are unable to find this desperoxamine, then we can give DTPA or calcium editate. Let's see the supportive measures after preventing the absorption of iron in the gut, and after giving this antidote we have to give the supportive measures, which are, we have seen that the patient will go into dehydration, right? So we have to balance this fluid and electrolyte. We have to check the acidosis, and even acidosis should be corrected. Okay, so this will be done with IV infusions. And we have to check respiratory and BP also. If there is a respiratory depression, then we have to keep that patient on continuous ventilation, and we have to check the blood pressure also. If the patient is having any convulsions, then we have to give diazepam through IV. So this convulsions we will in very few patients, then only we have to give this diazepam. Otherwise we don't need this diazepam. So by this we have learned so how we will prepare iron and what are the important preparations of iron. Thank you everybody. In tomorrow video, let's see what is vitamin B12, how it is observed and how it is utilized. Thank you and have a nice day.